I don't know if my talk will scare you into private practice or academics or privatemics. Like Mike, I'm in privatemics, although I took the opposite route as Mike and joined a large privatemic practice. So I didn't have to work to build my brand the way Michael has. But I'm going to switch gears a little bit and talk to you guys about value-based care and spine surgery. And I think this is particularly important for new practitioners because this is the future of how we're going to be practicing over the coming 3 to 5 to 10 years, certainly over your careers and lifetimes. So I think it's important. And it probably does have an influence as to the kind of practice you do choose to go into. No relevant disclosures for this talk. I think anytime you talk about value-based care, there's got to start by realizing that there is a problem with the US healthcare system. Otherwise, we wouldn't be looking to make changes in how we deliver care. And fundamentally, the problem is just a disparity between what it costs to receive care in the United States. We are an outlier in the rest of the world, and the results that we get. And those results have a lot to do with the fact that we spend more, but on a not per patient, but when you look at the entire population, we just don't perform as well as the rest of the world. The solution that's been proposed by a lot of folks, especially those in the academic circles, is the concept of bundle payments. And you hear a lot about the word value-based care and the definition of value being quality over cost. At the root of it are bundle payments, and these are particularly germane to orthopedic and spine surgery. And we've seen a lot of this already in hip and knee world, and it's coming more and more into the spine world. But the general concept is that delivery of care, purchasing care, should be as simple as purchasing a car and not as complex as it currently is in the United States. And so what I want to cover tonight briefly are what are the basics of bundle, what they are, how they work, what you need to be able to perform on them, and then go a little bit in depth into the different types of bundles that exist. So essentially what a bundle is a predetermined single payment for an episode of care. And so you get a lump sum for that care. And it includes all the care that's rendered during a predetermined period of time. Sometimes the bundle can be just the day of surgery. Sometimes it can include a period before and or after the surgery. And I think the most important thing is it includes the complications. So currently in the healthcare system, if you do a microdiscectomy and you get a post-op wound infection, certainly it's not fun to have to take that patient back to the OR, but we're financially compensated for that. In a bundle arrangement, you aren't. That's warranted. You've already paid for it. The payer's already paid for that. And so that infection's on you when it comes to the price of that. How do they work? So there's a trigger for the bundle. It's either a procedure or a diagnosis is what triggers it. There are certain inclusion-exclusion criteria, just like in research, there's inclusion-exclusion criteria. All these things are negotiated ahead of time. And then, like I said, there's a single upfront payment you get. The care is then delivered by the provider. And really, to be able to provide this care, you really need a care team. This is different. You can't go it alone as an individual surgeon. And then there's a following of the patient for a predetermined period of time, either before or after the procedure or the diagnosis. So what you need to be able to perform bundles, well, as a provider, you need to be both willing and able to do this. And this is different than typical fee-for-service. You've got to standardize care pathways. You've got to have that care team around you to help care for those patients. You've got to be able to assess the risk that you're going to have to take on and then be able to assume that risk. And to do that, you need some analytics, and you usually need to be able to have some reinsurance, because if a bundle goes really, really poorly, you're on the hook financially for it. And so a lot of times you're going to have to take out reinsurance. To be able to do all this, you need good data. So you need to know what your costs are. What are your true costs to deliver care? And then you need to know what your outcomes are. What is your quality data? So the main areas that are bundleable, while this is so germane, to us, are that the three biggest areas that payers are looking at are cardiac care, cancer care, and musculoskeletal. And the reason are, these are the three most expensive things, and they really do fall nicely into a bundle. Within the musculoskeletal space, the two areas that are in the most interest of payers, I would say, are total hip and total knee replacement and spine. And they're of great interest for different reasons. Hip and knee because they're high volume and highly reproducible. Spine because there's so much variability and there's so much different in spend that there's a lot of opportunity to be able to save money by creating a bundle. I think the big caveat when I talk about this is that spine is not joints, probably no joint surgeons on the call this evening. So in fairness, we do more than just 2 surgeries. We don't just do, a left hip and a right hip, or a left knee and a right hip. Also, in hip and knee surgery, the DRG code and the CPT crosswalk very closely. In spine surgery, they don't. And so you can have a DRG that can encompass a multi-level lumbar fusion, but it could also encompass a single lumbar fusion. And we know these are very different. We know that a spondy is not always a spondy. And we know about the alphabet soup of how we treat things, right? We treat things very differently. And that has a lot to do with the individual surgeon, the region, different reimbursement structures. So variation doesn't work well when you're dealing with bundles. When you got too many diagnoses, you have too many treatments, it creates too many bundles. And that's why spine's difficult, but creates a fantastic opportunity. So what are the different kind of bundles for specialists? This is a pretty busy slide, but I do want to focus in on just a few of these. The first ones are we call retrospective bundles. These are also known as shared savings. And folks may be familiar with these. These are the government programs, BPCI and CJR, that most of our hip and knee colleagues performed in, and some of us did for spine as well. The other procedure-based bundle are we call prospective bundles. And so instead of getting paid on the back end for how you perform, this is taking an upfront payment and then having to perform the procedure. So again, the difference between retrospective and prospective: retrospective is shared savings. It's a look back on what your historical trend and spend is, and they look to see if you can perform better. Prospective is very different. You negotiate a payment. You're going to get paid X to do a microdisc. You get an upfront payment. You then have to pay everybody else downstream, so the OR, anesthesia, rehab. And if you have that complication, you have to pay for it out of the money that you were given. So it's a very different kind of ownership of risk. Operationally, they're pretty simple. There's pretty narrow focus. It's focused on the procedure. So if it's a spinal fusion, that's the trigger. The problem is with the narrow focus, it doesn't capture all the non-surgical opportunity, which we know in spine there's a lot. And it also doesn't reward the avoidance of unnecessary surgery. In the hip and knee world, it's been estimated that 1/3 of total hip replacements and knee replacements are avoidable. If that's the numbers in the hip and knee world, I can only imagine what it is in the spine world. Value creation is pretty simple. It's pretty easy to remember. You have to know how much you're going to get paid and how much it's going to cost to do the treatment. And then the difference is what you keep in the end. So it's pretty simple to calculate the value creation when it comes to a procedure-based bundle. The more complex bundles, and which is where I think spine eventually is going to end up, is what's considered condition-based bundles. These are prospective bundles that are a single payment for a condition. So instead of being paid to do a spinal fusion, you're going to be paid to treat somebody who has degenerative spondylolisthesis, whether you treat it surgically or not surgically. So a condition-based bundle is different because this starts out with a diagnosis. So again, let's say spinal stenosis is the diagnosis. And you're going to get reimbursed for all the care you provide, both non-operatively for patients that don't need surgery. So you might think twice about how many injections you order or whether physical therapy is or isn't going to make a difference. And then if patients do require surgery, you're going to have to cover the perioperative period. And then you have to cover these patients for a longer period of time because condition-based bundles typically span a full year. How these work, again, the trigger is the diagnosis. So disc herniation in this example, not the surgery, because again, not all disc herniations need surgery. In fact, most don't. And then the episode of care is longer. It's typically a 6 to 12 month period. Now, the nice thing about this is you don't need pre-authorization to do surgery because you own the risk. So if someone has a disc herniation and you know they're not going to get better, you can go straight to surgery. You don't have to waste time or money on conservative treatment that aren't going to help. The value creation in this is a lot more complex. You have to understand the payment up front that you're going to get to manage this condition. You need to know how much it's going to cost to treat it conservatively. You need to know how much it's going to cost to treat it surgically and what % of the cohort that you're taking on risk are going to have surgery. I think in the end, as surgeons, we've got two fundamental decisions to make. We've got a choice. We can choose to focus simply on the surgery, what we do, in which case I think ultimately we're going to become technicians and downstream vendors to the primary care doctors that will take on this risk, and they'll call us if and when they want us to do a surgery. Or I think we are much better attuned as musculoskeletal providers to own this entire continuum of care and instead to be more entrepreneurial and for have us to manage this. The opportunities, I think you guys probably know, in spine are tremendous. There's a lot of upstream opportunity. Think about getting a plain x-ray as opposed to an MRI on every patient. Think about the utility of injections. Think about how useful braces are or not. The concept of disease prevention, right? We don't get paid very well to counsel patients to lose weight, stop smoking. In a condition-based bundle, you do. Then there's a concept of avoidable surgery. I quoted the 1/3 that's in the literature for total hips and knees. I'm sure in spine, the quotes in literature will be a lot higher if you really look at what's potentially avoidable. And then downstream, there's tremendous opportunity as far as avoiding unnecessary utilization of rehab or certain things after surgery. It all sounds wonderful and great, but obviously there's a lot of challenge in this, otherwise everybody would be doing this. These are difficult both to implement, and they're really difficult for the payers to adjudicate. So you've got to figure out what your trigger is. When does the bundle start? Is it just having the diagnosis? How do you confirm it? How do you attribute the bundle? Does it go to me as the surgeon? Does it go to my colleague as a primary care doctor? Who's responsible for it? How do you price out these things? That's very difficult. The payers know how much it costs for them to pay for these diagnoses over a year, but they're not always willing to share that information with us. And then the final thing is you've got to look at changing provider behavior, which, having practiced in a large group, I can attest is not always the easiest thing to change individual surgeons' behavior, how they like to practice. So I'll leave you with that final thought from Albert Einstein, but I think it's some food for thought. In our training and early on, we learn really well who to operate on and how to operate, but how we get paid is going to be a bigger part of what we do. Thanks.